Welcome to the Deep Dive. Today we're tackling a really critical area in the world of trauma medicine, injuries to the major blood vessels inside the chest, or what's known as thoracic vascular trauma.
That's right.
Now, most chest injuries, thankfully, don't require surgery. But when these big vessels are involved, well, the situation becomes incredibly serious, with alarmingly high mortality rates.
It does. When these vital pathways for blood flow are compromised, rapid and precise action is just paramount.
Yeah.
In this field, the speed and accuracy of diagnosis and treatment can truly mean the difference between life and death. It's that stark.
Our goal today is to really dig into our current understanding of how these high-stakes injuries are identified and managed. To do this, we're drawing on the deep well of knowledge contained in Rutherford's Vascular Surgery and Endovascular Therapy, specifically the 10th edition. So, we're getting in some seriously authoritative material here.
And it's vital to recognize the immense progress that's been made in this area. I mean, the last couple of decades have brought about a real transformation in how we approach thoracic vascular trauma.
A transformation, yeah.
Definitely. We now have much more sophisticated imaging techniques and, importantly, less invasive treatment options. It's really been a remarkable evolution.
Absolutely. And as we unpack this, I think you'll experience a few of those aha moments as we connect the dots between diagnosis and the latest treatment strategies.
Hope so.
We're going to be focusing on the two primary ways these injuries occur, through blunt force trauma and as a result of penetrating injuries. So, are you ready to get started?
Let's do it. Let's begin with blunt thoracic vascular trauma. Our sources indicate that these injuries are surprisingly common, accounting for roughly 8% of all trauma admissions in the United States.
8%. That's a notable number. And what's particularly interesting is that the most frequent cause, it's something most of us encounter daily: motor vehicle crashes.
Right. They are responsible for over 70% of these cases. 70%, wow.
Precisely. However, it's really important to underscore that despite how frequently blunt chest trauma occurs, the vast majority of people who experience it will not require any surgical intervention inside the chest.
Okay, that's a key point. Now, within the realm of blunt thoracic trauma, there's one specific injury that stands out due to its potential severity: blunt thoracic aortic injury, or BTAI.
Yeah, BTAI. What's concerning about BTAI is that it's a leading cause of death following blunt force trauma, second only, really, to head injuries.
Second only to head injuries.
The statistics are quite stark. The mortality rate before patients even reach the hospital is tragically high, estimated to be between 80 and 85%.
80 to 85%. Those figures really emphasize the critical nature of these aortic injuries. So when a patient with suspected BTAI does make it to the hospital, what's the initial process? How do you figure out the extent of the damage? Well, the initial assessment is comprehensive. It starts with a detailed account of how the injury happened, the mechanism of injury combined with a careful evaluation of the patient's vital signs and a thorough physical examination.
What are you looking for in the exam?
Certain findings can raise suspicion, things like swelling of the neck veins, any shift of the windpipe, or a noticeable difference in pulses between the arms, for instance. A standard chest X-ray or CXR is also a routine first step.
And one might assume that if there's a major tear in a vessel as large as the aorta, the chest X-ray would show a very clear picture of the problem, wouldn't it?
That's a natural assumption, but it's actually a bit of a misconception.
Oh.
Yeah. While some findings on a CXR, like a widening of the mediastinum, that central compartment in the chest, can suggest a BTAI, the test isn't particularly sensitive.
How insensitive.
Studies indicate it only picks up about 33% of these injuries. So a normal chest X-ray certainly doesn't rule out the possibility of an aortic injury. Not at all.
Okay, so a chest X-ray can offer some initial clues, maybe raise suspicion, but it's not the definitive answer. What's the next step in getting a more precise diagnosis then?
This is where computed tomography angiography, or CTA, has truly revolutionized the field.
Okay.
It's now the established gold standard for diagnosing injuries to the thoracic aorta. The accuracy rates are excellent, with sensitivity ranging from 96 to 100% and specificity between 95 and 99.8%.
96 to 100% sensitivity. That's huge. So a CTA provides a much clearer and more reliable image. Are there any other imaging tools that might come into play in specific circumstances?
Yes, intravascular ultrasound, or IVUS, can be a valuable tool in certain situations.
IVUS. Okay, how does that work?
Imagine a very small ultrasound probe attached to the end of a thin tube, which is then threaded through a blood vessel, usually starting from the femoral artery in the groin.
Right up into the aorta.
Exactly. This allows us to get real-time, detailed images from inside the aorta itself. This is particularly helpful when the findings on a CTA are not entirely clear, or if there's evidence of bleeding around the aorta, a periaortic hematoma, without a definite tear being visible on the CT scan.
That sounds like it could provide a really close-up view. What are the sort of pros and cons of using IVUS?
Well, the benefits are that it doesn't require any additional contrast dye injected into a vein or exposure to more radiation, and it can often be done using the same access point in the groin as a standard angiogram.
Makes sense.
However, there are some drawbacks, including the cost of the specialized equipment and single-use catheters, the need for a slightly larger sheath, the catheter compared to some other procedures, and it can add a bit of time to the overall procedure in the OR.
You mentioned angiography earlier. With CTA being so prevalent now, what's the current role of angiography in diagnosing BTAI? Does it still have one?
It does, but it's shifted. Angiography, which involves injecting contrast directly into the blood vessels and taking detailed X-ray images, was indeed the diagnostic gold standard in the past.
Okay.
However, with the advancements in CTA technology and its widespread availability, angiography's primary role has shifted more towards treatment planning and sometimes as a backup if CTA is inconclusive. It's still essential if an endovascular repair, a minimally invasive procedure we'll discuss shortly, is being planned.
Okay.
The limitations of angiography include its more invasive nature compared to CTA, the cost, the use of contrast and radiation, and the need to potentially transport a critically ill patient to a specialized angiography suite.
Yeah, that transport can be risky. It sounds like imaging technology is really advanced to give us a much better understanding of these injuries. But are there any situations where what we see on the images might be misleading? Could you get a false positive?
That's a really important question. Yes, there are some normal variations in anatomy that can sometimes mimic an aortic injury on a CTA or angiogram. Things like a ductus diverticulum, which is a small outpouching that's a remnant from fetal circulation, or sometimes just the way certain arteries branch off the aorta can look a bit unusual.
Oh.
But experienced radiologists and vascular surgeons are skilled at differentiating these normal variations from true traumatic injuries by looking for other signs of trauma, like a collection of blood in the mediastinum or around the aorta, or the presence of an intimal flac, which is a tear in the inner lining of the aorta.
So it's not just about spotting something on the scan. It's about interpreting those findings within the larger clinical picture of the patient.
Exactly. Context is everything.
Okay, so we've diagnosed a BTAI. Now, how do doctors determine the severity of the injury? Is there a grading system?
There is. Blunt thoracic aortic injuries exist on a spectrum of severity, ranging from very minor tears in the inner lining of the aorta all the way to a complete and life-threatening rupture.
And where do they usually happen?
The aortic isthmus, which is a slightly narrower section of the aorta just after the arch, is the most common site of injury. This is because of the significant forces of rapid deceleration that occur in events like car crashes.
Makes sense.
We typically use a 4-grade classification system to categorize these injuries based on the depth and extent of damage to the aortic wall.
Okay, let's go through each of those grades. What does each one signify?
So grade 1 involves an intimal tear, which, as I mentioned, is a tear in the innermost layer of the aorta. These can be quite subtle and are often best visualized on CTA or IVUS. In fact, a traditional angiogram might even appear completely normal.
Okay, grade 1, intimal tear. Grade 2.
Grade 2 injuries involve what we call an intramural hematoma, which is bleeding within the wall of the aorta itself, or a dissection where the layers of the aortic wall begin to separate. These grade 2 injuries typically cause an irregularity in the outer contour of the aorta and can be seen on all 3 imaging modalities, CTA, IVUS, angiography.
Got it. Hematoma or dissection. Grade 3.
Grade 3 is a pseudoaneurysm. This is essentially a contained rupture where the bleeding is walled off by the outer layers of the aorta or surrounding tissue. These are usually quite easily visible on any of the imaging techniques.
A contained rupture.
Okay.
And grade 4.
Finally, grade 4 is a free rupture, which is exactly what it sounds like, a complete tear all the way through the wall of the aorta. This is also, unfortunately, very clearly seen on imaging, often with active bleeding.
That breakdown makes sense. So a grade 4 injury is obviously the most immediately dangerous. What's the typical distribution of these different grades in patients who actually make it to the hospital with a BTAI?
It's interesting. About half of the BTAIs that are diagnosed in the hospital are grade 3 injuries, the pseudoaneurysms.
Half for grade 3.
Yeah, grade 1 injuries account for around 25%. grade 2 for about 15%, and the most severe grade 4 injuries make up approximately 10% of those who arrive at the hospital.
That's a helpful perspective on the relative frequency. Now, I understand there's also a more simplified way to classify these injuries that relates more directly to treatment strategies.
Yes, exactly. Starnes and colleagues proposed a simpler three-tiered system, categorizing BTAIs as minimal, moderate, and severe.
Okay.
This classification was specifically developed with the different approaches to treatment in mind. Minimal injuries correspond to the SVS grade 1 and some grade 2 injuries, where there's no significant deformity of the aorta's outer shape and the intimal tear or any associated thrombus. A blood clot is less than 10 millimeters in size.
Less than 10 millimeters. Okay. Minimal.
Moderate. Moderate injuries align with SVS grade 3 and include any visible abnormality in the aortic contour, like a pseudoaneurysm or an intimal tear larger than 10 millimeters.
Got it. And severe.
Severe injuries equate to SVS grade 4, characterized by active bleeding or a contained rupture with a significant collection of blood around the left subclavian artery.
So this more simplified system really bridges the gap between how we describe the injury and how we might go about treating it. Okay. Let's talk about that treatment. What's the very first step in managing all BTAIs, regardless of how severe they are?
The immediate management for every BTAI, whether it ultimately leads to surgery or not, involves what we term anti-impulse therapy.
Anti-impulse therapy, what's that?
It's essentially a very aggressive approach to controlling the patient's blood pressure and heart rate. The primary goal here is to reduce the stress on the injured wall of the aorta and thereby minimize the risk of it rupturing. Studies have clearly demonstrated that this initial medical management can significantly decrease that risk.
So you're trying to calm everything down. What are the specific target numbers for blood pressure and heart rate in this anti-impulse therapy?
The generally accepted targets in most medical centers are a systolic blood pressure, or SBP, of less than 120 millimeters of mercury.
Less than 120 systolic.
And a heart rate below 60 beats per minute. This is often achieved through the continuous intravenous infusion of beta blocker medications like esmolol.
So for some of these injuries, could medical management alone actually be the definitive treatment?
Yes, absolutely. For grade 1 injuries, anti-impulse therapy is often the only treatment required.
Just manage the blood pressure and heart rate.
Correct. For grades 2 through 4, while the initial thinking, reflected in guidelines from the Society for Vascular Surgery, was that medical therapy served mainly as a bridge to surgical or endovascular repair.
Right, buying time.
Exactly. But there's growing evidence suggesting that even some grade 2 injuries, those classified as minimal aortic injuries, can be safely managed non-operatively with ongoing medical therapy.
Really? Even grade 2?
Yeah. Recent research and data from the large Aortic Trauma Foundation registry have shown very low rates of the injury getting worse or of patients dying from aortic-related causes in this select group who were treated without immediate intervention. Some studies even showed no failures in grade 2 patients managed medically.
That sounds like a notable shift in how we approach these less severe aortic injuries. But what about situations where this medical-only approach might not be the best course of action? Are there complexities?
That's a crucial point to consider. For instance, patients who have also sustained a traumatic brain injury, or TBI.
Yes. Polytrauma.
Exactly. They might actually require a higher blood pressure to ensure adequate blood flow to the brain. This directly conflicts with the goals of lowering blood pressure in anti-impulse therapy for the aortic injury.
A real dilemma.
It is. In these more complex scenarios, a close collaboration between neurosurgeons and vascular surgeons is absolutely essential to determine the optimal treatment strategy, carefully balancing the needs of both injuries.
Makes sense. Multidisciplinary approach.
And we also need to be constantly vigilant for any signs that the medical therapy isn't effectively controlling the situation, such as evidence of malperfusion, worsening blood flow to the organs, or signs on imaging that the aortic injury is progressing.
Yeah.
If that happens, you have to abort medical therapy and intervene.
And what have been the outcomes for those patients who are managed definitively with medical therapy alone for their BTAI? You mentioned the ATF registry.
Yes. The data from the Aortic Trauma Foundation Registry, which represents the largest collection of such cases to date, has shown encouraging results. They reported low overall in-hospital mortality rates for patients who were carefully selected for medical management as their sole treatment.
That's good.
Notably, there were no deaths directly related to the aortic injury in this group. However, it's important to mention that a small percentage of these patients did eventually require some form of intervention later on, maybe down the line.
Okay, so for more severe injuries or when medical management isn't the right fit or isn't working, what are the options for repair?
Well, while historically, immediate open surgical repair was the preferred approach.
Get in there right away.
Right. But current evidence suggests that in some trauma, patients with multiple severe injuries, delaying the aortic repair to first address more immediately life-threatening conditions like bleeding in the abdomen or head injury might actually lead to better overall survival.
Delaying, interesting.
During this period of delay, medical management with anti-impulse therapy is continued. Then, when the patient's condition is stable enough to undergo aortic repair, the modern standard of care for those with suitable anatomy is thoracic endovascular aortic repair, or TEVAR.
TEVAR. That sounds like a less invasive alternative to traditional open surgery. How has it changed the way BTAIs are treated?
TEVAR has truly revolutionized the treatment of BTI. It has largely replaced open surgical repair in many specialized centers
Why is that?
because it's associated with lower rates of complications and death. Significantly lower. The first endovascular device specifically approved by the FDA for treating thoracic aortic aneurysms was introduced in 2005.
For aneurysms first, okay.
Yes, and the subsequent approval of devices specifically indicated for traumatic aortic injuries in 2008 further solidified TEVAR's role as the preferred approach in most trauma cases.
Could you briefly explain what the TEVAR procedure involves? What actually happens?
Certainly. It's typically performed under general anesthesia in a specialized operating room equipped with advanced X-ray imaging capabilities, often a hybrid operating room.
Hybrid or, right?
We usually gain access to the aorta through the femoral artery in the groin. An angiogram of the aortic arch, called an arch aortogram, is performed to precisely locate the aortic injury.
Find the spot.
Exactly. Intravascular ultrasound, IVUS, as we discussed earlier, might also be used at this stage to provide additional detailed information about the injury. The patient receives anticoagulation, medications to prevent blood clots,
Heparin, usually.
usually heparin, yes, and then an appropriately sized endograft, which is essentially a fabric-covered stent, is selected based on the preoperative CT scans.
The sizing is crucial, I imagine.
Very crucial. This endograft is then delivered to the site of the aortic injury through a catheter and deployed, essentially sealing off the tear or rupture from the inside of the aorta, relining the aorta, basically. In some cases, to ensure a good seal, we might need to intentionally cover the origin of the left subclavian artery, which is a vessel that supplies blood to the left arm.
Cover an artery. What happens then?
If this happens, we often perform a separate, delayed procedure to restore blood flow to the arm, like a bypass. Sometimes balloon angioplasty, where a small balloon is inflated inside the endograft, might be used to ensure it's fully expanded and securely pressed against the aortic wall.
Make sure it's sealed well.
Precisely. At the end of the procedure, any blood-thinning medication given, like the heparin, is usually reversed.
So TEVAR is now the primary approach. When is traditional open surgical repair still the necessary or preferred option?
Open surgical repair, which involves a traditional surgical incision to directly access and repair the aorta, is now generally reserved for specific situations.
Such as?
These might include cases where the patient is in critical condition with dangerously low blood pressure, hemodynamically unstable, and endovascular resources aren't immediately available, or maybe the expertise isn't there at that moment. It's also necessary when the patient's anatomy isn't suitable for TEVAR. For example, if there isn't a sufficient landing zone, a healthy section of aorta above and below the injury where the endograft can be securely anchored, or if the iliofemoral vessels in the groin that we use for access are too small or significantly diseased, too calcified perhaps.
Okay, so anatomical limitations or extreme instability. What are the common surgical incisions and techniques used for open repair of a BTAI?
There are several standard surgical approaches, including an anterolateral thoracotomy, a posterolateral thoracotomy, a bilateral thoracotomy, sometimes called a clamshell incision.
Clamshell, yeah, big incision.
Big one, and a median sternotomy. For injuries to the aortic isthmus, which, as we've noted, is the most common location for BTAI, a left posterolateral thoracotomy, an incision on the left side of the chest going around to the back, is often the preferred method. The key steps in open repair involve carefully clamping the aorta both above and below the injured segment to stop blood flow.
Cross-clamping.
Exactly, cross-clamping. And then using a technique called distal aortic perfusion to maintain blood flow to the lower body and spinal cord during the time the aorta is clamped for repair.
You mentioned distal aortic perfusion. What are some of the specific techniques used for that? How do you keep blood flowing down there?
The most common technique is what's known as left heart bypass, where blood is diverted from the left ventricle of the heart, or sometimes from the left inferior pulmonary vein, back into the aorta below the level of the injury using a pump.
So you bypass the clamp segment.
Precisely. In more complex or rare situations where gaining control of the aorta above the injury is particularly challenging, full cardiopulmonary bypass with hypothermic circulatory arrest might be necessary.
Whoa, circulatory arrest, stopping the heart.
Well, stopping circulation temporarily, yes. This involves temporarily stopping the patient's circulation entirely while the repair is performed under conditions of mild cooling, hypothermia, to protect the brain and other organs.
Open aortic surgery sounds like a significant undertaking with potential risks. What about the strategies employed to protect the spinal cord during these procedures? That seems like a major concern.
Spinal cord protection is of paramount importance during open BTAI repair. Absolutely. Clamping the aorta can interrupt blood flow to the spinal cord, potentially leading to paraplegia.
Yeah, devastating complication.
It is. We use a variety of strategies to minimize this risk, including draining cerebrospinal fluid, CSF, from around the spinal cord to reduce pressure,
CSF drain.
inducing mild hypothermia to slow down metabolic activity in the spinal cord, carefully managing the patient's blood pressure and oxygen levels, and in some cases, even reattaching key intercostal arteries that supply blood to the spinal cord if possible.
So whether a patient undergoes TEVAR or open repair, what does the immediate care look like after the procedure? What happens in the ICU?
Close monitoring of the patient's vital signs and overall condition in the intensive care unit is crucial, along with meticulous management of any other injuries they may have sustained. Polytrauma management continues. Blood pressure targets might need to be adjusted based on the presence of other conditions, like a traumatic brain injury or a spinal cord injury, again, that balancing act. We also closely watch for any potential complications such as bleeding, infection, or new neurological changes. Interestingly, current evidence does not support the routine continuation of prophylactic antibiotics after the surgery itself.
No routine post-op antibiotics.
Not generally, no. And because TEVAR is a relatively newer technique compared to open surgery, long-term data extending beyond 10 years is still somewhat limited.
Still gathering that long-term data.
Exactly. Our typical follow-up protocol involves clinical examinations and CT angiograms at 1, 6, and 12 months after the procedure and then annually thereafter.
And for the non-op patients.
Patients who are managed non-operatively are typically advised to avoid heavy lifting and strenuous activities until their injury shows signs of healing on follow-up imaging. Gotta let it heal.
Let's delve a little deeper into the potential complications. You mentioned that TEVAR has generally led to improved outcomes compared to open repair. Could you elaborate on some of those differences?
Yes, the available data strongly suggests that TEVAR is associated with a lower risk of several early complications when compared to open surgical repair.
Like what specifically?
This includes a reduced likelihood of early death, paraplegia, kidney dysfunction, the need for blood transfusions, the requirement for reoperation due to bleeding, cardiac complications, pneumonia, and a shorter overall stay in the hospital.
That's quite a list of benefits.
It is. Studies from both the Aortic Trauma Foundation and the ASB BTAI study group have consistently demonstrated these advantages, including lower rates of blood transfusions and improved survival rates with TEVAR.
That's certainly compelling evidence in favor of TEVAR. But are there specific complications that are more commonly associated with this endovascular approach? Nothing's perfect, right?
True. While less frequent now, with increasing experience and improvements in device technology, certain access-related and device-related complications can occur with TEVAR.
Such as?
These might include the endograft being placed in a slightly incorrect position during deployment malposition, or the development of endoleaks where blood continues to flow outside the graft but within the original aneurysm sac or injured area.
Leaks around the graft.
Yeah. Also, the endograft shifting its position over time, migration and complications at the site where the catheters were inserted in the groin, like hematomas or pseudoaneurysms at the access site.
Okay.
Fortunately, these types of complications appear to be relatively uncommon in experienced centers. And in the event that a TEVAR procedure isn't initially successful, or if a problem develops later, it's often possible to perform a subsequent intervention, either another TEVAR procedure or open surgery, to salvage the situation.
So there are options if it fails.
Yes. We also need to be mindful of potential complications related to selecting the correct size of the endograft that's critical, and dealing with challenging anatomical features such as a very curved aortic arch or diseased, narrow, or tortuous access vessels.
So when we look at the overall picture, what are the typical outcomes for patients after undergoing management for a BTAI in recent years? What does the survival look like?
The 2015 Aortic Trauma Foundation study, which looked at a large cohort of patients across numerous major trauma centers, provides valuable insights. They reported an overall in-hospital mortality rate of approximately 19% for all patients with BTAI.
19% overall.
But importantly, this rate varied significantly depending on the initial treatment strategy. It was highest for those managed non-operatively, though that group often includes the sickest patients or those deemed unsuitable for repair.
Right, selection bias there.
Exactly. Followed by those undergoing open repair, and lowest for patients treated with TVAR.
Lowest mortality with TVAR.
Yes. And mortality directly related to the aortic injury followed a similar trend. Importantly, the study found that the majority of aortic-related deaths occurred before any definitive repair could be performed.
They died before intervention.
Many did, and those who died after repair often had very severe overall injuries, as indicated by high injury severity scores, or ISS.
So polytrauma played a big role.
A huge role. Statistical analysis revealed that a higher overall injury severity, a higher ISS, and a higher grade of BTAI were independent predictors of aortic-related death, while treatment with TEVAR appeared to have a protective effect on multivariate analysis.
That really underscores the positive impact that TEVAR has had on improving survival rates for these complex injuries. Now, despite all the advancements we've discussed, are there still areas where there's debate or ongoing research in the management of BTAI? Still things we're figuring out?
Oh, absolutely. Plenty. Well, the current guidelines from the Society for Vascular Surgery offer a valuable framework for treatment. They do have certain limitations, particularly in that they tend to focus primarily on the characteristics of the aortic injury itself, maybe not enough on the whole patient picture sometimes.
Okay.
And as we touched on earlier, there's ongoing discussion about the optimal management of those minimal aortic injuries, especially grade 2 BTAIs.
The non-operative management question.
Precisely. Emerging evidence strongly suggests that non-operative management can be a safe and effective strategy for many of these patients, but more long-term prospective studies are really needed to definitively guide clinical practice.
Need that longer follow-up.
We do. Another significant challenge lies in managing BTAI in patients who have also suffered other serious injuries, such as a traumatic brain injury. We talked about the conflicting
The
goals.
blood pressure conflict, yeah.
Right. And some research even suggests that early aortic repair might actually worsen outcomes in patients with TBI. So timing is critical and complex.
So the timing of repair is still debated.
Very much so. Determining the ideal timing for BTAI treatment in general remains an active area of investigation, with different sets of guidelines sometimes offering slightly different recommendations. There's a continued need to identify specific risk factors that might predict early rupture of a BTAI to help guide that timing decision.
What else?
We also need more data on how durable TEVAR devices are in the long term, 10, 15, 20 years out, what the optimal sizing strategies are, particularly in pediatric patients or those with smaller aortas, that's a big challenge, and more independent multi-center studies to refine the indications for different endovascular devices.
And technology keeps evolving too, right?
Absolutely. The development of branched endograft devices, for example, which could potentially eliminate the need to cover the left subclavian artery during TEVAR in some cases, is also a very promising area for future development.
Okay, that's a really comprehensive overview of blunt thoracic aortic injury. Fantastic. Now let's shift our focus slightly to vascular injuries affecting the aortic arch vessels and the vasculature of the thoracic outlet, the other big pipes up there.
Right. These injuries, which involve vessels like the innominate, subclavian, and carotid arteries in the upper chest, are also serious and are frequently initially identified using contrast-enhanced CT scans, which, as we've discussed, are a standard part of the evaluation for major trauma patients.
Same diagnostic tool, pretty much.
Largely, yes. And similar to BTAI, the patient's overall medical condition and the presence of any other associated injuries are critical factors in determining the most appropriate management strategy.
And instability is key again.
Absolutely. For patients who are hemodynamically unstable, meaning their blood pressure and circulation are critically compromised, especially following a penetrating injury like a stab wound, initial open surgical repair is often necessary. You have to stop the bleeding fast.
Let's discuss some of the specific vessels in this region. What about injuries to the ascending aorta and the transverse arch, the very beginning of the aorta?
Rupture of the ascending aorta or the transverse aortic arch is thankfully not very common, but when it does occur, it is often rapidly fatal. Very high mortality.
What signs might you see?
These types of injuries are frequently associated with a widening of the mediastinum on chest X-ray and can lead to cardiac tamponade, where blood accumulates rapidly in the sac surrounding the heart, compressing it.
Tamponade, right.
Repair typically requires a median sternotomy, an incision down the middle of the chest, along with the use of cardiopulmonary bypass, heart-lung machine, to support the patient's circulation.
Full bypass.
Often, yes. For injuries involving the aortic arch itself, we might even need to employ deep hypothermic circulatory arrest, similar to what we discussed for some complex BTAI repairs, combined with techniques to maintain blood flow to the brain called cerebral perfusion.
Huge operations.
Massive. Ultimately, survival in these very severe cases is heavily dependent on the severity of any other injuries the patient has sustained.
And what about injuries to the innominate artery, the brachiocephalic?
The innominate artery, which is the first and largest branch off the aortic arch, supplying blood to the right arm and the right side of the head and neck. It's actually the second most common thoracic arterial injury resulting from blunt trauma after the aortic isthmus.
Second most common from blunt trauma. How are those repaired?
These injuries are generally repaired through a median sternotomy, sometimes with an extension of the incision into the right side of the neck to gain better access. Because blunt injuries to the innominate artery usually occur near its origin from the aorta.
Right at the takeoff.
Yeah. A common and effective repair technique is to create a bypass graft, connecting the ascending aorta to the innominate artery beyond the injured segment and then tying off the damaged portion. We typically don't need to use temporary shunts or cardiopulmonary bypass for these repairs, usually just clamp control.
Okay, a bypass graft. Moving on to the left, common carotid artery.
The surgical approach for injuries to the proximal left common carotid artery, knew its origin from the aortic arch, is similar to that used for the innominate artery, a median sternotomy, potentially extending the incision into the left side of the neck.
Similar approach.
Yes. When the injury involves the very beginning of the carotid artery, using a bypass graft for repair is generally preferred over attempting to directly reconnect the severed ends in end-to-end anastomosis.
Okay. What about if the patient already has neurological symptoms? A stroke?
That's a complex and somewhat debated topic, managing carotid artery injuries in patients who already have neurological deficits. However, if the patient is seen relatively soon after the injury, revascularization restoring blood flow is usually recommended.
Why?
Because low blood pressure, hypotension from the trauma is often the primary contributing factor to any neurological symptoms at that early stage, rather than a fixed stroke necessarily.
Got it. Restore flow quickly.
Exactly. Interestingly, endovascular techniques are being increasingly used to treat traumatic carotid artery lesions, particularly those located near the base of the skull, where traditional surgical access can be really challenging.
Endovascular for carotids, too.
Yes, using stents or covered stents. The goal of these endovascular procedures is to eliminate any abnormal connections, fistulas, bulges, aneurysms, or narrowings, while ensuring good blood flow to the brain. Patients typically require antiplatelet medications after the procedure to help prevent blood clots from forming within the stent.
Antiplatelets, right. And finally, let's discuss injuries to the subclavian vessels under the collarbone.
Injuries to the subclavian vessels, which carry blood to the arms, are most frequently caused by penetrating trauma, such as gunshot or stab wounds. Blunt injuries are less common here.
Mostly penetrating, okay.
Before any surgical intervention, obtaining detailed preoperative imaging, usually a CTA, is crucial for planning the surgical incision and understanding the precise location and extent of the injury. You need a roadmap.
Definitely need the roadmap. How do you approach them surgically?
For injuries to the right subclavian artery, a median sternotomy with an extension into the right side of the neck is often the most effective surgical approach to get proximal control. For the left subclavian artery, we might use a left anterolateral thoracotomy, sometimes combined with a separate incision above the clavicle, a supraclavicular incision to gain better control of the vessel further down.
Different approaches for right versus left.
Yes, due to the anatomy. While it's technically possible to connect these two incisions, the thoracotomy and supraclavicular, with a sternotomy, This combined trapdoor type incision should be used cautiously due to reports of increased risk of postoperative nerve pain and other complications.
Okay, maybe avoid that if possible.
If possible. Often, injuries to the more distal portions of the subclavian artery, further away from the chest, can be accessed and repaired without needing to resect the clavicle or perform a sternotomy.
And endovascular here too.
Yes, similar to the aortic arch vessels we've discussed, endovascular approaches are becoming increasingly utilized for treating injuries to the innominate, intrathoracic, carotid, and subclavian arteries in both blunt and penetrating trauma scenarios.
Is the evidence strong for endo in these areas?
Emerging evidence suggests that in carefully selected patients, endovascular treatment can lead to better outcomes compared to the often technically demanding open surgical repairs in these challenging anatomical regions. Studies focusing on axillosubclavian injuries and broader analyses of thoracic vascular injuries from national databases support this trend.
Better outcomes.
Potentially fewer complications, less blood loss, maybe faster recovery. However, it's important to acknowledge that we still have a significant lack of long-term outcome data for endovascular repair in these specific areas.
Again, the long-term question.
Exactly. It underscores the importance of ongoing data collection efforts through registries like PEER-OVERVET, the Prospective Observational Vascular Injury Treatment Registry, to address this critical gap in our knowledge. We need to know how these repairs hold up over time.
This has been an absolutely fascinating and incredibly informative deep dive into the complex world of thoracic vascular trauma. It's clear that while these injuries remain a significant challenge in trauma care, remarkable progress has been made,
Definitely.
particularly in the realm of diagnosis with advanced CT imaging, and in the initial management with the increasing use of endovascular techniques like TVAR.
Yes, the advancements in this field over the past 2 decades have been truly remarkable. It's changed dramatically. But as we've discussed, there are still many unanswered questions and areas where ongoing research is essential to further refine our treatment strategies and improve the long-term outcomes for these patients.
It's certainly encouraging to hear about the ongoing research efforts being conducted by groups like the Aortic Trauma Foundation and the PROV registries. These initiatives are undoubtedly going to be crucial in continuing to advance our understanding and ultimately improving the care we provide to patients with these critical injuries.
Absolutely. These collaborative efforts are vital for driving progress in this complex field and ensuring that we can offer the best possible outcomes for individuals who suffer these devastating injuries.
So, reflecting on everything we've covered today, especially the rapid evolution of minimally invasive endovascular techniques, it really sparks the question, what future breakthroughs might we see that could further transform the management and long-term results for individuals who experience these critical thoracic vascular injuries?
It's exciting to think about. Branch grafts, lower profile devices, maybe even bioresorbable materials someday. Who knows?
It's definitely something to think about. Thank you for joining us for this deep dive.